This child is one of the luckiest children in Ethiopia, as she was born under the care of professional doctors. She has a most likely chance of celebrating her first birthday. Of course, Ethiopia succeeded in meeting the MDG4 target of reducing mortality rate of under 5 children 3 years ahead of 2015.
As we all know, in 2012, Ethiopia has met the MDG4 target by reducing the under 5 mortality rate by 2/3 from its 1990 level.
However, the death of children in Ethiopia is still not acceptable figure to any country in the world. If we look into the age structure of this under 5 mortality rate, the neonatal accounts for 43%.
The under 5 and the neonatal mortality rates for Ethiopia are estimated at 68 and 29 per 1,000 live births respectively. Taking estimate of 3 million annual births, the country has absolute number of under 5 children, and the neonates dying each year in the country will be to under 4,000 and 87,000 respectively.
This is why the core group Ethiopia, in collaboration with its partners, organized a workshop under the title Social Mobilization and Demand Creation Plan for Improved Newborn Care at the Salin Hotel, Addis Ababa from March 4 to 6, 2015. 81 participants representing pertinent governmental and non-governmental organizations deliberated for 3 days with the main objective of developing plan for social mobilization and demand creation to improve newborn care in Ethiopia with a special focus on pastoralist and semi-pastoralist areas. The workshop started with welcoming an introductory speech by Dr. Filimona Bisrat, Director of CGPP Ethiopia.
The workshop aimed to develop social mobilization and demand creation plan on newborn health for pastoralist and semi-pastoralist areas.
In his keynote address, Mr. Yosef Girma, Program Director of CCRDA, appreciated Ethiopia's achievement in reducing under 5 mortality rate and acknowledged the political commitment of the government as well as coordinated effort of development partners. However, he revealed the disparity of pertinent health services and results among different regions of the country is a great concern.
Based on the 2000 EDHS survey result, while the under 5 mortality rate for Addis Ababa was 53 per 1,000 live births, it was 124 Ethiopia and Somali, 169 for Benishangul Gumuz, and 123 for Gambela regions.
Mr. Yosef underscored the lessons drawn from the core group polio project in the hard-to-reach areas in Ethiopia could be useful in developing and implementing the plan for improved newborn childcare. Mr. David Shanklin, a core group international representative, on his part explained the rationale of his organization's intervention in Ethiopia and at global level. He said core group is a member of maternal and child support program funded by USAID. He summarized the global situation of under 5 mortality rate, of which the neonatal takes 45%, to justify why the first week of a child's life is important.
Especially in areas that are marginalized and under-resourced, we particularly think that involving civil society to advocate for newborn health, to increase demand, and to empower parents, families, and communities to take actions for themselves to lower these rates is extremely important.
Dr. Helena Kabede, on behalf of His Excellency Dr. Kabede Werko, State Minister of Health, started her speech by lauding Ethiopia's success in meeting the MDG4 target ahead of time and the ongoing improvement to achieve MDG5 through reducing maternal mortality by 3/4 from its level in 1990. She also elaborated on efforts made by the government following the national health policy dated 2 decades back that ensured access to maternal, newborn, and child health services, particularly to pastoralist and semi-pastoralist regions. Dr. Helena appreciated CCRDA core group's effort to help regions that require equitable development and hoped the workshop would come up with a plan that can be used to increase the demand for newborn care in pastoralist and semi-pastoralist areas of the country.
Minister of Health wants to express its support for our initiative to actively participating in this workshop in the coming 3 days, and also supporting the implementation of the plan in those specific areas.
Dr. Alfonso Rosales, a senior advisor at Core Group USA, was the first to present discussion points on the global overview of newborn health. He said knowing the fact that almost 90% of the death among the newborn children is preventable makes it tragic.
Almost every year, 4 million newborns die globally. This represents almost 3 times the combined number of deaths due to HIV/AIDS and malaria.
Dr. Rosales also mentioned that the global decline in neonatal mortality has not been proportional for all regions of the world. His presentation elaborated more on global efforts and improvements as well as challenges and opportunities in addressing the problem globally. He finally introduced the call of every newborn action plan for an increased annual average reduction rate from 2.7% to 4.7% to achieve national newborn mortality rate of 10 or less and global average of 7 per 1,000 live births. The next presentation by Dr. Lisanu Tadesse, Newborn Health Advisor to the Federal Ministry of Health, dealt with the national newborn programs, focusing on the current status and plan. He noted the opportunities to accelerate the coordinated efforts of the government and its partners to improve newborn care. He also remarked every newborn action plan as one indicator of the national commitment renewed and discussed the existing platforms to deliver newborn care services. He also discussed the challenge the Ministry of Health has been facing in implementing newborn care plans, especially in the hard-to-reach areas. Following the two presentations, the moderator, Professor Bogala Warqu, Executive Director of Ethiopian Pediatric Society, summarized key points and opened the session for discussion. Participants reflected on presentations and raised questions that were addressed by the two presenters.
What about the role of the civil society organizations? Because health is not really, we cannot address only through the public structure. So I think the plan should be inclusive of all the public, CSOs and private sectors.
In the next session, Dr. Alba Bekele, Project Director of Mother and Child Support Program at the Save the Children Ethiopia, presented on the experience and readiness of the health system in implementing CBNC. She mainly discussed the 4Cs approach that CBNC uses. Those are contacting pregnant women and newborns, capturing sick newborns, providing care to sick newborns or women, and ensuring those who started treatment complete the full course of treatment. She also shared Save the Children's experience in implementing CBNC program through training of health extension workers and conducting post-training follow-up visits. Following Dr. Ababa's presentation, representatives of Oromia and Ethiopia Somali Regional Health Bureaus reflected on the readiness of their respective health systems. Mr. Yadesa Itefa of Oromia explained that only 30% of the two pastoralist zones in the region, Guji and Borana, are beneficiaries of CBNC. Mustafa Dek of the Somali Health Bureau on his part stated the shortage of human resource, medical supplies, finance and leadership to implement MNCH care in the region. Again, participants discussed on Dr. Ababa's presentation and statements of the two regional representatives. Some of them were questions which were answered by relevant presenters. The next presentation was delivered by Mr. Legese Bezabe, Deputy Director of Core Group Polio Project, focusing on CGPP's achievements, lessons learned, and opportunities for newborn social mobilization and demand creation. He started the presentation by giving background information about CGPP in general and its intervention in 5 regions of Ethiopia in particular. According to his presentation, CGPP reached 5.6 million people in pastoralist and semi-pastoralist areas through 12 CGPP member organizations. He discussed the achievements made and challenges faced by CGPP and identified 2 major experiences to be taken as lesson to apply in implementation of newborn care initiative. The first one is community-based surveillance and the second, newborn tracking for oral polio vaccine zero. Participants reflected and raised some questions on Mr. Legace's presentation, and he gave answers to all of them. Experience mapping exercise was the next part of the workshop, where the participants were divided into 4 groups. Using the provided templates, each group compiled information about background of the project, place it was implemented, key strategies used, outcome of the SMDC initiative, and challenges faced. Following the completion of their exercises, all the groups presented their findings and the preliminary discussed. In the next session, participants reviewed draft objectives and defined the target beneficiaries of the SMDC. They therefore agreed on revised general objective and left technical phrasing of the specific objectives to the facilitators. They also defined direct and indirect target beneficiaries for the SMDC plan. Reviewing methods on the family healthcare and BCC materials, strategies or opportunities to integrate delivery of the newborn methods in CGPP's existing platform, and determining key activities of the SMDC plan were among the key activities dealt in group and plenary sessions. The last technical session of the workshop was stakeholder analysis. Participants identified potential national and local stakeholders and determined their possible primary roles. Finally, participants recommended CGPP to develop and test SMDC model appropriate to pastoralist and semi-pastoralist areas, pilot project the model, and scale up the project to all pastoralist and semi-pastoralist areas. The workshop concluded by acknowledgement and closing remarks by Dr. Filimona Bisrat.